So welcome everybody. Let's see, I'm going to try my weekly recap of everything that's come before. So you learned about introduction to public health, why are we doing this? Then we heard from Angela Donadell, representing community-based health initiatives. Then we heard from Dr. Kristen Oliver, talking about data sets. We heard from Dr. Andy Aline, talking about long-acting reversible contraception, his LARC initiative. We heard from, who am I missing now? Last week was Charlene Gordon. I think I'm missing one in between, aren't I? Is that it? This is the 7th session at any rate. Well, we're switching gears again as is the point of the course. We want to flesh out as many facets of public health as possible to give you as much exposure to the world that lies ahead in the brief hour that we have each week. So this is one of my favorite lectures. I'm really glad our speaker is able to join us again today. So Dr. Noé Romo works up at Jacobi, as you can see from his title slide. And he is someone who, in the course of his professional work, his sort of regular job, as you might say, he realized that there was a problem that he couldn't adequately address from within the clinical space. And so he developed a method, working with partners, of course, to more adequately address the problem, specifically of violent trauma in his part of the Bronx. So I'll turn it over to Noé to really describe exactly what he and his partners are doing and how effective it is. Thanks for joining us, Noé.
No problem. Thank you, Cap. As always, it's always a pleasure to be here. Always a pleasure to meet all of you. Obviously, the last 2 years has been virtually, which is okay. I'm so happy to be involved and talk to you guys a little bit about violent trauma, specifically this year about the epidemic of violent trauma that persists. And just so you know, we're going to go a little bit through some of the epidemiology of violent trauma, both nationally and locally, and then talk a little bit about the hospital-based intervention that we are using up at Jacobi to address this epidemic of violent trauma. So essentially, as Kat mentioned, we'll talk a little bit first about the problem, and then what we're doing to address it, and then the problem that persists and how we go about going forward in this ever-changing world of this pandemic of ours. So first and foremost, I think it's important to kind of start a little bit with kind of where we are in terms of the epidemiology of violent trauma. When we talk about U.S. firearm-related homicides, this is data from 16 years, from 1999 to 2015, looking at firearm-related homicides in individuals aged 0 to 24, stratified by race and sex. So who wants to take a stab at this? Let me know what pattern they see in this table. Anybody?
Well, it's a heck of a lot higher for Black non-Hispanics.
Yes, a heck of a lot higher being the technical term, of course.
Yes,
yes, indeed. So when you look at the rate per 100,000, right, Black non-Hispanic males are essentially murdered by firearms in the rate of 31 per 100,000, followed by Hispanic males at a rate of 8 per 100,000, compared to white non-Hispanic males at a rate of 1 per 100,000. So just think about that for 1 second, right? Black non-Hispanic males are being essentially murdered by guns in this country at almost 30 times the rate as young white males. So that should be disconcerting news to anybody. This is national news that has unfortunately not changed. The data has not changed much over the last 6 years since this data was collected. Furthermore, when we look at leading causes of injury deaths in New York City, this is 9-year data from 2002 to 2011. So as a pediatrician, as a pediatric hospitalist, I'm in charge of taking care of any patient that get admitted age newborn to 21 for any type of admission. So an injury-related death is something that in my mind is preventable. So when we look at injury-related deaths in New York City, at less than 1, the majority of deaths that happen in New York City in kids are sleep-related. From age 1 to age 14, the majority of injuries are also from what we call accidental injuries, right? Whether it be fire injuries, whether it be fires in the home, or accidental fire-related injuries in terms of like stove injuries or hot food injuries, and then followed by motor vehicle crashes, all accidental injuries at age 5 to 14. But between age 14 and 15, there is something that happens in terms of the epidemiology of injury, death in New York City, where the leading cause of injury, death in New York City shifts from motor vehicle crash to firearm-related death. And this is in a city, by the way, that has some of the strictest gun control laws in the country, where the leading cause of injury, death between age 15 and 17 still remains firearm-related death. More specifically, when we look at certain neighborhoods within New York City and firearm-related deaths, this is data from 2002 to 2011. What we find, the areas that are more highlighted in darker purple are areas that have higher incidence of rates per 100,000 of firearm-related deaths in individuals aged 15 to 17. So what we notice here is that, not surprising, the areas that are darkest in purple are areas of the South Bronx. The Bronx is pretty much all lit up in purple, including the Northeast Bronx. Jacoby is right around here, almost right in the center of the Bronx here, including areas of East Harlem, specifically the South Bronx. East Harlem has the highest rates, along with Bedford-Stuyvesant, East New York have some of the higher rates, whereas right in lower parts of Manhattan, you see the areas are almost go to 0 per 100,000. Now, what neighborhood is this right here?
East Harlem.
That's East Harlem. That is the area where Cap is sitting at now, pretty much, more or less. What street do you think this is right here? Straight line in the middle.
The magic boundary.
The magic boundary. Which magic boundary is that, Cap?
You guys know?
What street is this, guys?
It divides Upper East Side from East Harlem.
94th,
Plus,
110.
6th Street.
96th Street.
Oh.
Exactly. This is 96th Street. So just think about that for 1 second. If you are on the north side of 96th Street and you are a 15 to 17-year-old, your rate of dying from homicide there is about 12 to 20 per 100,000. If you're on the south side of 96th Street, your rate is 0 per 100,000. So talk about discrepancies, right? This is one street separating your, like, literally your risk of dying from firearm from 0 to 20 times. One street that divides those two neighborhoods and separates your risk for dying, like, at a young age. So this map kind of personifies a problem of gun violence in New York City, and why it's important to not just look at citywide data in terms of firearm-related injury, but look at more, not just borough-specific data, but also specific data based on neighborhood and based on race and ethnicity. When we look at homicides throughout this country at some of the 3 major metropolitan areas that tend to be some of the areas with the highest rates of gun violence. So this is data looking at last year's information on firearm-related homicides in New York City, Baltimore, and Chicago. And these are all rates per 100,000 number of rates. So when you look at New York City in 2020, we had 462 murders in New York City last year with a population of 8.6 million. Now that is just concerning because prior to 2020, New York City had gone almost 3 straight years with going under 200 homicides a year. So it was quite the pinnacle, actually, because New York City had not achieved that for over 50 years in 2017 and 2018 and 2019. So 2020 was definitely a different year in terms of homicide. But when you compare that to other cities, Baltimore, population of 621,000, had 335 murders. Chicago, with almost a quarter of the population of New York City, had 769 homicides last year. Now, it's important to look at these numbers, right, from an epidemiologic standpoint, not just look at the raw numbers, because it looks like, hey, Chicago is doing worse than both Baltimore and New York, but because the populations are so different, right, and then the population density is different, then you have to look at the numbers per 100,000. So when you look at the numbers per 100,000, although the total numbers of Baltimore seem to be the lowest of all 3, per 100,000, Baltimore actually has the highest, 53 per 100,000, followed by Chicago at 28.5 per 100,000, followed by New York City at 5.4 per 100,000. So comparatively, this is why it's important to always look at the end when you look at numbers when people are reporting. Because if people just say, well, look, Baltimore is doing better than New York City and Chicago in terms of homicide, so the problem is not that bad there. It's not right to say that, like, without looking at the population context and the population density. But when we look at these numbers, these are all numbers. We look at homicide numbers. We like to pat ourselves on the back saying, well, you know, our rates per 100,000 are not as bad as Baltimore and Chicago. So New York City must not be in such bad shape. But when you look at the effects of violence and violent trauma, each of those numbers, each of those deaths is responsible for a lot of these makeshift memorials that arise in street corners throughout different urban neighborhoods in the US. And these are all memorials that are placed to commemorate somebody who has died, somebody who has been murdered. More and more of these arise. People walk by these every single day. So just imagine growing up in a neighborhood where you are a toddler or an infant and you are sitting there commemorating somebody's murder. And you're walking by these every single day, looking at them, knowing that somebody was shot and killed in that area that you are walking by. The level of stress that it adds in terms of like what happens to you and the stress level that it acquires in terms of adverse childhood events is enormous. And it's understated in terms of the effects of gun violence. So we know it's a problem. We know that there are issues around different inner city neighborhoods with violence and violent trauma. And the problem has been there for years, as you saw from the numbers. So then what can we do about it and what is next, right? As a pediatric hospitalist at Jacobi, I am responsible, as I mentioned, for taking care of any patient that gets admitted from newborn to age 21. And being a level 1 trauma center, I trained there as a resident at Jacobi. What we saw was that, there was a lot of patients that came in who were shot, stabbed, or assaulted, who we did an excellent job at caring for their physical wounds, but we would send them right back to the community where they were from, and a lot of them came back. It turns out that the rate of recidivism is quite high. So in individuals who are the victim of violent trauma, whether you're shot, stabbed, or assaulted, you are 3 times more likely to come back with another violent injury within 3 months of that time frame. So then the question we asked was, how can we engage in prevention efforts for violent trauma? How can we use almost an infectious disease model for engaging in primary, secondary, and tertiary prevention? So who can tell me what is a prime example of primary prevention of a disease using an infectious disease model? What would be primary prevention? Anybody?
Nation?
Yeah. So primary prevention is preventing a disease before it ever even happens, right? So vaccination is a hot topic these days, obviously, in terms of the COVID vaccine. So that
it's political.
Very political as well. But from an infectious disease standpoint, strictly speaking, from an infectious disease standpoint, we know that vaccines are a primary form of prevention because it prevents you from getting the illness or from getting sick from the illness before you even get sick, right? So how can we do that for violence? How can we prevent the violence before it even happens? Does anybody have any ideas of what we can do for primary prevention to prevent violence before it even happens? How can we inoculate populations to not engage in violent behavior?
Community outreach.
Okay, community outreach in what way? What specifically could you do perhaps to prevent somebody from being victimized or being engaged in violent activities?
I would say maybe address some of the circumstances that encourage the violence, like maybe finding after school programs or activities for youth and things like that.
Yeah, trying to find some way to address the underlying issues, the underlying risk factors that influence violent behavior. Okay, now secondary prevention. What is secondary prevention in terms of an infectious disease model? What would be an example of secondary?
Treating the disease.
Right.
Before it gets worse.
Correct. So secondary prevention, what's crucial here is almost like early detection, right? So early detection is crucial because you could treat early on to prevent its progression. So let's say, for example, like the use of mammograms for breast cancer, right? So like you do routine mammograms, there's recommendations to do them at certain ages so you can pick up a change in a woman's breast early on. So if you see a change, you can target it locally, you can maybe go in there, surgically take it out, maybe even do chemotherapy early on, but you prevent that cancer from spreading. So you screen early to get ahead of it early so that it doesn't spread. So you treat the disease early. So what would be a way, let's say, to engage in secondary prevention for violence? What do you guys think?
Maybe doing like mental health screenings.
Okay.
Or I don't know how to screen for violence, but I would say that I think maybe mental health screenings are probably a good indicator of whether or not somebody would be prone.
Yeah, so mental health screenings are definitely helpful, in particular if you're looking at, so when we talk about risk factors for engaging, so being victimized by violent trauma while also being the victim of violent trauma, if you have a gun in the home, one of the risk factors is having mental health illness of you completing an act of homicide or an act of suicide. So if you have a gun in the home, you are 3 times more likely to successfully commit suicide and 4 times more likely to successfully commit a homicide. So yes, so mental health screening could be important in terms of trying to screen individuals. So that's a good one. What else? What about community violence? Maybe not so much related to mental health. What would be a secondary form of prevention? Perhaps hospital-based. So I think I mentioned it there, right? So maybe treating victims early on, because maybe there's a gradation in terms of violent trauma, right? Maybe identifying people who get assaulted, right, before they get stabbed or get shot, or identifying individuals in the hospital who are admitted because they're jumped, and then it turns out you find out, hey, they're actually part of a gang or part of a crew, and they're talking about retaliation. So how can we get them out of that mentality? How can we prevent them from coming back? So you're catching it early.
Do it without dehumanizing them, like, oh, you're a gangster, you're a bad person.
Of course. Yeah, of course. That's critically important.
Like, counsel through with them.
Yeah, I think that's critically important to humanize people and make them not feel bad about themselves or what they're engaging in, provide them with alternatives and provide them with understanding. You're right. And not just label them as somebody who's a gangster or who's out there doing stuff on the streets, but being able to understand what's going on and really getting ahead of the issues without being judged. That's good. And tertiary prevention is the last form of prevention. That is really treating a disease that has already progressed a good amount, and you're trying to really just prevent it from getting worse. So in looking at the breast cancer model, similar to that is, okay, so maybe somebody has missed their mammograms and they come already to the doctor, they have a big lump in one of their breasts. At that point, you're already highly suspicious that it's cancer. You do a biopsy, you know it's cancer. So it's like, okay, you know what? This is progressed already. Let's say it's already invaded the entire breast. So now we have to do extensive chemotherapy, perhaps even do a mastectomy, which is remove one of the breasts, so prevent it from spreading to the rest of the body. So at that point, the disease has already progressed and you're just trying to mitigate it so that it doesn't lead to more serious health issues, if not death. So for violence, that would mean treating a serious violent injury. Let's say somebody's already shot, and they have a significant injury. Let's say they get shot in the leg and they have a fracture. So, okay, yeah, we're going to treat their fracture, but let's get ahead of it now. Let's figure out why they were shot. Let's see what led to them being injured and how can we safely discharge them back to their neighborhood so that they're not getting re-injured again and they're not engaging in whatever activity they were engaging in that led to them getting injured. So this all sounds great, and it all sounds like a great way to look at it, but it's not as easy as, let's say, like an infectious disease, right? It's not like we just come up with a vaccine against violence and be like, okay, everybody get it, and then nobody's going to shoot each other anymore. It's not like you could just do that or have good screening tools to prevent it. So it's a little bit more tricky. So then the question becomes, how do you start an intervention program? How can we actually take this model of primary, secondary, tertiary prevention and essentially inoculate a population to be able to try to prevent violent trauma from happening? So in terms of starting this hospital-based intervention program, it's really, really hard, right? First, you have to start with the data. First, you have to start looking at, okay, so what's going on in the neighborhoods that I'm working at? For us, it was in the Bronx at Jacoby, which is level 1 trauma center. But we were approached by New York State, who at the time was working with the Department of Criminal Justice to try to develop a network of community outreach programs geared at violence prevention. So these community outreach programs were looked at using what they called violence interrupters or community outreach workers, who are people from the community who can essentially counsel people and mediate disputes before they escalated to prevent violence from happening. So, and this program was called SNUG, statewide, which is gun spelled backwards. I know, not a very cool name. How are you going to call a violence prevention program SNUG? It's just gun spelled backwards, but hey, that's what they did. And our idea here was to say, how can we make this same community program essentially, but make it based out of the hospital? We are a city hospital. We are a level 1 trauma center. So how can we have 2 arms, both a hospital component and a community component, where we not only engage in secondary and tertiary prevention in the hospital, meaning we see all the patients who come in who are assaulted, who are shot, who are stabbed, try to counsel against retaliation, but also provide resources. But how can we also have a network of community outreach workers in the communities from where our patients are coming from that can kind of incorporate models of conflict mediation and intervene in disputes before they escalate. So we did just that. We applied for the grant through New York State. We called the program Stand Up to Violence, and we started in 2014 with our program over at Jacoby. And so SUV is one of 12 New York State Snug Street outreach sites across New York State. We are funded, as mentioned, by the Department of Criminal Justice. We started in August of 2014. And we target specific blocks in certain neighborhoods of high volume shootings, in particular in the 43rd, 47th, 49th precincts, and along with treating patients in the hospital who are admitted for either assault, stab wounds, or assault or gunshot wounds. We have now been labeled an in-house model program in terms of being the only New York State funded hospital-based intervention program, and a model that was declared by former Governor Cuomo as an in-house model that was to be spread throughout the state and to be mimicked across the state as well. So essentially what we do is we hire what we call street outreach workers who live in the communities where they work. So all these individuals live within the 43rd, 47th, 49th precincts in our designated target areas. And there are individuals who are credible messengers, which means they have had similar experiences to a lot of the youth that they're aiming to help. Our target age range is individuals aged 14 to 25 who are at the highest risk of being involved with gun-related trauma and with violent trauma. And these individuals live in these neighborhoods. They grew up in these neighborhoods. They know what's going on. They know the active disputes in the neighborhoods. They know the active crews and gangs that are having issues and the rivalries that have ensued. And we also hire a hospital responder who's an individual also from these neighborhoods who is able to see patients, identify with them, and essentially just become a mentor in the hospital and provide them with services like which I will get more into a little bit later. But I think the biggest thing is that we employ individuals who would have otherwise had a hard time finding employment. A lot of these individuals have had criminal backgrounds in the past, criminal records. A lot of these people have not even gotten their GED or finished high school. So it's very, very hard for them to get jobs. So it's essentially also a model for effective reentry practices. And in fact, is one of the state's largest and strongest reentry programs because we hire a lot of individuals who were previously incarcerated. So as I mentioned, our program has a hospital and a community component. At the hospital component, as I mentioned, we respond to all individuals who are victimized for violent trauma. We counsel against retaliation. We coordinate medical care. We improve their clinic follow-up. We provide a lot of different support and social services, meaning like whatever people need while they're here, whether it's housing, whether it's linkage to educational services, job training services. We also provide linkages directly to crime victim services, which is a New York State service that provides kind of any kind of like money to people who have been victimized of violent trauma to help cover any costs, including costs incurred, hospital-related costs, if you lose any property, any lost income that you lost as a result of your injury, and even funeral costs, unfortunately. For those individuals who have died, New York State will help cover funeral costs. And I think the biggest thing is that we're trying to change the hospital norms. We're trying to change the way we view violent trauma, and that it's not just about treating the physical wounds, it's about treating the whole patient, and it's about providing them with services and try to prevent re-injury, using their hospitalization as a teachable moment where we can get a sense of what's going on in the community and prevent these individuals from being re-injured. At the community level, the goal is to change behavior and community norms around changing the kind of global acceptance around violent trauma and the resulting death and the devastation that it has. We identify high-risk individuals. These are any individuals aged 14 to 25 who are actively engaging in violent trauma or have been victimized. We have multitude of community events and canvassing to promote nonviolent means of conflict mediation. And we do shooting responses where we respond to any shooting that happens in our target areas. This is an example of one of our shooting responses where we all go out, all of our outreach workers go out to the location where the shooting actually happened to commemorate the shooting and to just march essentially and to let people know that a shooting happened there. And we incorporate local leaders, community leaders, religious leaders to come out and march with us. In the summer, we have multiple basketball tournaments, which COVID significantly disrupted that. But we just finally this summer, we were able to start having some more basketball tournaments. And these are crucial because they bring communities together. They're a pillar of the community. Basketball tournaments really bring the community together. And the more basketball tournaments we have, the less shootings we have. Now, like in all nights where we do basketball tournaments, there are no shootings that night in those neighborhoods. We attend different community events, whether it be holiday events and whatnot, just to support our local community centers. Here's our CEO standing with 2 of our outreach workers at National Night Out, which is like the national night of that all police departments throughout the country come out to support the community. So like we have the support of our CEO and support of our Department of Social Work and Trauma Surgery and Pediatrics. In our shooting responses, we have peace walks also every summer. We walk through our neighborhoods to promote peaceful walking, promote the fact that people can walk in peace through these neighborhoods. And again, we respond to every single shooting. We take it all very seriously and we view it as a personal failure because too often these shootings are normalized in these communities. And by going out there, like we're able to denormalize them and bring it to the front end that this is something that should not be accepted. So in terms of our community hospital data, I'm going to go through now some of our data. When we looked at the data from 2014 to 2018, we compared it to the 4 years prior. So we started here in 2014. From 2014 to 2018, we were able to decrease the shootings by 44% pre and post our community intervention. So percentage numbers are good, but as an epidemiologist, I also have to look at things like as they relate to chi-square and p-values, which I'm sure Cap is going to tell you a lot more about as the year goes on. So
we'll save it for Epi.
You save it for Epi. Well, full disclosure, I have a master's in Epi, so I apologize. I'm a little bit of a nerd when it comes to epidemiology, so I apologize for the nerd talk in advance, but I'm sure this will all make more sense when you do your Epi. But numbers are good, but like I said, 4 years before SUV, we had 113 shootings. The 4 years after SUV, that's 64. It looks like a decrease, right? But when we look at numbers per 100,000, we had 8.1 per 100,000 before the SUV program, 4.5 per 100,000 after the SUV program. That gave us a chi-square of 14.8 and the magic p-value number less than 0.001, suggesting that this was a statistically significant difference pre and post our intervention at the community level. However, since then, our numbers have changed a little bit, as you can see. After 2018, our numbers rose a little bit. 2019, 2020, for sure, we went up to 18. And then now we are already at 13 with still a little over 2.5 months left in the year. So our numbers have been creeping up a little bit over the last couple of years. We'll go into that a little bit later. Our fire-related homicides, since the program started, our homicides were down significantly until last year, where our homicides went up to 6, which is the highest they've been since we started the program. And currently now we are at 2 homicides so far this year, and we're hoping that trend continues. In terms of the hospital, we know that, whenever we have one gunshot wound victim, there will likely be retaliation for that gunshot wound, and a second gunshot wound victim will come in, a second injury or death will occur, and the cycle will continue. So at the hospital level, it becomes essential to intervene in patients in this first victim to prevent that cycle from circling, and understanding why that individual was injured here, so we could prevent that individual not just from being re-injured when they get discharged, but also from promoting retaliation and allowing more patients to come in later on. So as I mentioned, we have a community and hospital component. So now we're going to go through some of the hospital data that we've seen since the program started. This is our hospital response team. This is me in my work gear when I'm seeing patients now. Since COVID, everything has changed. So now we wear scrubs whenever we see patients every single day. This is Caitlin Bear, who's our social worker. She is in charge of seeing every single patient who is a victim of violent trauma. She's in charge of all their social work services. This is Kadeem Nichols, who is our SUV hospital responder. He is an individual who lives in the community, who lives in the Bronx, who was previously incarcerated as well, who now sees patients along with me and our social worker for our hospital-based intervention. So since we started the program, we started in 2014, these are the number of patients we've seen. We responded to 1,796 patients over that 7-year span. So this is kind of a hard graph to interpret, but the orange line is gunshot wounds, the yellow line is stab wounds, and the green line is assaults. So who wants to take a shot at this bar graph and tell me what trends do you see here?
I see like gunshot wounds is most trending than stab wounds and assaults, but it has gone down in 2021, 2022-ish, I have to guess.
Yeah, well, so like the 2021, 2022, that's the information from July. So this goes by the academic year, which for us in medicine starts from July 1st to June 30th. So the 2021, 2022 data is just from July 1st, 2021 of this year until now. So it's a couple of months worth of data. But when we look at 2020, 2021, what we see, you're right, is that gunshot wounds have trended up significantly. Last year, we had 118 gunshot wound victims that were responded to at Jacobi, which is the most we've ever had. And we outnumber the number of stab wounds that we are seeing and the number of assaults. In the previous calendar, in like academic year 2019, 2020, we had 75 shootings. The previous year, we had 59. 56 actually. And for the 3 years prior to that, actually, when you look closely, stab wounds were outnumbering the number of gunshot wounds for 3 straight years until 2019, 2020. And then last year was a significant difference that we saw. When we looked at data from the first 4 years of our program, we analyzed our patient data and said, okay, how can we look at certain outcomes to see if we're making a difference? So how can we look at if patients are coming back for more than half of their scheduled follow-up appointments, and how can we look at if we're having an impact on re-injury? So when we looked at our demographic variable, the majority of our patients were not surprisingly male, the majority were Latino and African-American, and the mean age was 19. And table 2 shows our logistic regression model outcomes, where we looked at our major exposure was were patients seen by our program, and our major outcomes was, did patients go to more than half of their scheduled follow-up visits, and did patients return back with a re-injury during the study time period with a violent trauma. So we saw, so what this odds ratio means, I know you guys haven't taken epi yet, but an odds ratio greater than 1 suggests that you are at higher odds of having that outcome. So essentially, if you were seen by SUV, you had 2.3 times the odds of coming back for more than half of your scheduled visits, which in layman's terms basically means you were almost 2 times more likely to come back to more than half of your clinic visits after you were discharged, which is good because it means you were being adherent to your treatment plan and your outcomes were better. If you were seen by our SUV team, you had 0.4 times the odds of coming back with a re-injury. It sounds weird to say, but what that means essentially, if your odds ratio is less than 1, it means you're less likely to have that outcome. So if you were seen by us, you essentially had 59% decreased chance of coming back with a re-injury during the study time period. So essentially, you were able to decrease the incidence of re-injury by almost 59%, which is good, which means we were trying to prevent these patients from coming back. So this is not bad in that we were able to improve the rates of re-injury. So, hey, like mission accomplished, our lecture should be done, pat myself on the back, everything is good, right? We decreased the rates of re-injury over 4 years, improve the rates of follow-up. So I could just call it a day and say mission accomplished, violent trauma has ended, right? Well, not so much, because we have been living in this COVID world, post-COVID world. And the question then arises, what happened to violent trauma during and post the COVID-19 pandemic? So interestingly, what we saw at Jacobi, the pandemic, the official order of the lockdown order in New York City started in March 20th, 2020. And we looked at data up until August 31st of 2020. And what we saw was that the top part is daily trauma presentations at Jacobi during that time period. And the 3 bottom graphs show you COVID cases, COVID hospitalizations, and COVID deaths. So what pattern do you guys see here when you look at the pattern of daily traumas at our hospital and daily COVID cases, hospitalizations, and deaths during that first wave of the COVID pandemic in New York City?
No, I did the dates correlate for all 4 graphs?
Yes.
Okay.
Sorry, I think the x-axis is a little bit smaller, some of the COVID graphs, but yes, they're March 1st, April 1st, May 1st, June 1st, July 1st, August 1st, and September 1st, 2020.
Getting into the summer months, it seems that you saw more trauma presentations. So after like some stay-at-home orders started to lift.
Correct. Yeah, exactly. So as the stay-at-home order went into effect and the cases were the worst in the Bronx, right? Peak right here around April 1st and April and May, right? our violent trauma cases were pretty low. We had about maybe 2 a day, if that, right? And then what happened after June 1st? You start seeing more trauma cases coming in daily. And what happened to COVID cases, hospitalizations, and deaths during that time? Down. So there appears to be an inverse relationship between COVID cases, hospitalizations, and deaths and trauma presentations, right? So why is that? Why is it that as COVID peaked, violent trauma went down, and as COVID went down, violent trauma went up? Why do you guys think that happened?
Well, people might be experiencing the psychological trauma of
Okay.
COVID, and
Mhm.
that could be resulting in more violence.
100%, right? So the Bronx remains a borough of New York City to date that has had the largest number of cases, hospitalizations, and deaths from COVID. 1 in 3 people in the Bronx know somebody who was hospitalized for COVID. 1 in 6 people in the Bronx know somebody who died from COVID, right? So just think about that. We were disproportionately hit by the COVID pandemic. A lot of stress load goes along with that. You know that when you have high stress load, you're more stressed. Your impulse control is probably not the best. So if you're upset at somebody, you happen to have a gun, you're more likely possibly involved in that. Okay, so that's one reason. What else?
So the question is, why did violent behaviors increase inversely according to the incidence of COVID?
I think it's because of the mental trauma of being crammed indoors for months and months.
Okay, that
I
too.
mean,
Yep. Yeah,
Say it again.
Good job, Nick.
So unemployment as a stressor.
correct. So those unemployment rates went up specifically in these areas of the Bronx. A lot portion of the population here works in places like the service industry, which was disproportionately hit with unemployment. So there was the unemployment stress. You're right. There was the isolation stress. People were isolated from each other, isolated from their families, isolated from their friends. Right. Schools were closed. School was remote. That support network was gone. Community centers were closed. There was no after school programs, right? So there's a lot of multiple reasons why these things could happen. But let's look at the data first better and see. So what happened, right? So this is a graph looking at trauma statistics from 2018 to 2021, from March to August of 2020, 2020 and 2021, and 2018 and 2019. So what we did here was we looked at, okay, from March to August, there was definitely an increase in violent trauma in 2020 post-COVID. And then the question was, all right, well, like, how does it compare to other years? And how does it compare to this current year, right? So when we look at March, August 2018, 2019, we had about 179 and 126 incidents of violent trauma for an average 153 total during that time period in 2018, 2019. We compared it to March, August 2020, we had 201, right? And this summer, from March to August, we saw 230, right? So when we averaged out kind of what we saw in terms of the average, so from March to August 2020, 21, the average is 215 compared to the average of 2018, 2019 during that same time period. That was a 40% increase in violent trauma that we saw at our hospital these past 2 years compared to the 2 years prior. More specifically, when we looked at gunshot wounds, we had for an average of 32 gunshot wounds in 2018, 2019 combined average. And the past 2 years, 90. So we had a 180% increase in the number of gunshot wound victims that we saw at our hospital the last 2 years from March to August compared to the 2 years prior. That is critical, right? And then when we looked at other types of violent trauma in terms of stab wounds and assaults, those remained, pretty steady, a slight increase of 2 and 6%. Not negligible. Any victim is not negligible, but nonetheless, nowhere near as significant as the amount of gunshot victims that we have seen. So we saw a significant increase in the number of gunshot wound victims in our hospital compared to years prior. And more specifically, the age group of 15 to 24-year-olds was more targeted. They had a 33% increase in total violent trauma and 146% increase in gunshot wounds only. So 15 to 24-year-olds were disproportionately affected for both total violent trauma, but also specifically in gunshot wound injuries compared to other groups during that same time period. So when we look at the Jacobi data versus the total Bronx data, so the borough of the Bronx to date, as of October 3rd, has seen a 33% increase in shootings and a 39% increase in homicides compared to the year prior, like up until October 3rd. compared with citywide data, with citywide, all of New York City has seen a 1.6% increase in shooting victims and a 2.2% increase in decrease in homicides. So this is why it's critically important to look at not just citywide data, but look at borough specific and neighborhood specific data, because when, like if we just look at the city as a whole, you're saying, oh, we're doing pretty good. We've had a little bit of an increase in shootings, but not too bad, and a decrease in homicides. So we're actually doing better as a city. We are as a city level, but certain neighborhoods are being disproportionately affected. Specifically at Jacoby, as I mentioned, we've seen 180% increase in gunshot wound victims. And when you look at, compared to the same year prior, significant increase now, like in 2020, 2021, we saw 53% more gunshot wound victims than we had seen the year prior. But in our target areas, nonetheless, we are seeing a decrease actually. So when you look at, like, as I mentioned, the Bronx overall is seeing a 33% increase in shootings. In our SUV target areas to date, we've seen a 23% decrease in shootings and a 50% decrease in homicides. We're not patting ourselves on the back yet, but compared to the rest of the Bronx, our target areas are doing better compared to what everybody else is doing. But nonetheless, I like to say every single shooting is an unacceptable shooting. In terms of, we mentioned a little bit of COVID and firearm-related injury. So violent trauma has definitely increased nationally in the setting of the COVID pandemic. Data is now coming out nationally about the increase associated with the COVID pandemic. There's definitively been a documented increase in firearm-related injury in children under 12, where there's more injuries and deaths in children under 12, like secondary to firearms since COVID. And it also coincides not just with the multiple socioeconomic issues and stressors that we mentioned, but it also is coinciding with a significant increase in firearm purchases nationally. So there's been about a 68% increase in gun purchases since the COVID pandemic started nationally. There's a lot more guns that have been purchased. And whenever there's an increase in gun sales, surprise, surprise, gun deaths also increase, right? Who would have known that when you sell more products of death, death rises? It's such a weird thing, right? But what happens is when these guns are purchased legally, it also increases the flow of illegal guns. So although New York City has strict gun control laws, guns do flow into New York City from the outside states and outside areas that don't have looser gun control laws. And there is a significant increase in available guns in the streets now compared to where they were prior to the pandemic. The Bronx, as mentioned, had the highest rates of people living below the federal poverty line. New York City has the highest rates of people living below very high levels of poverty, specifically children. Close to 48% of children in the Bronx living below the federal poverty line. It has the highest proportion of New York City residents who are Black, African American, or Hispanic, or immigrant population. So the Bronx is at the epicenter of socioeconomic factors that influence both COVID-19 outcomes and violent trauma victimization at the same time. So like everything else, COVID exacerbated a lot of underlying socioeconomic factors that were lying below the iceberg that have now been brought to the surface and are really put people at higher risk for both violent victimization and COVID victimization as well. When we look at the health impact pyramid, right, and how things affect people's health and what factors can impact people's health, what we're doing at the SUV level, we are counseling patients, we are having a clinical intervention up here, we are trying to institute long-lasting protective interventions in terms of the community outcomes we are looking at, using community outreach workers. We're trying to change the context in which people make decisions. But these socioeconomic factors are at the base of this pyramid, right? And we are fighting against these factors that we're having a hard time mitigating. We try to do things like do job training and get people jobs and improve education. But as long as these socioeconomic factors persist and factors related to social justice, factors related to social determinants of health, it's going to be really, really hard to have a long-lasting impact. And we're going to need, but as you know, if you're intervening at this level, you have increased population impact, whereas intervening at this level has less of a population impact and it involves more individual effort. But these factors are a little bit harder to mitigate from a clinical standpoint, and that these would necessitate having input from local, state, and national political leaders try to address some of these issues. And I guess what we are learning here is that we have a cautionary tale of two Bronx epidemics with opposing epidemiologic curves, right? Because what we saw is that there's an inverse relationship in COVID cases related to violent trauma. So then the question becomes, how can we make the violent trauma curve look like the COVID-19 curve, where it decreases in incidence and decreased hospitalizations and deaths related to violent trauma? So in summary, in terms of the program, this is just a slide summarizing some of our data that we just mentioned in terms of our hospital data and our community data and the composition of our program. And as I mentioned, we have been identified by New York State as a best-in-class model. We have acquired some further funding now from Mayor de Blasio. We're expanding into 2 other neighborhoods in the Bronx, where we are going to hire more outreach workers. And this new area was identified by both our hospital and community data and active disputes that we have identified. We have also received additional funding from New York State to expand our network of outreach workers within our already existing areas, and also to expand the social work services that we have available. We've also received some additional funding from Congresswoman Alexandra Ocasio-Cortez, who we met with multiple times, and she's providing us funding to improve the mental health services we're able to provide to our patients and to our population. As some of you mentioned, the mental health strain that COVID has caused has created a huge influence of violent behavior, so trying to address that. And most recently, as I mentioned, ex-Governor Cuomo identified as the best-in-class model. He declared a state of emergency in terms of violent trauma because of the increase in shootings that we had been seeing, and quoted us as a model program to be replicated throughout the state, with the goal of having every single trauma center to follow our lead and use our model to implement throughout the state, to have a state network of hospital-based violence intervention programs to address a violence like the disease that it is. So this is an example of taking a national program and applying it locally to a local epidemiology that reflects what's going on nationally, make it based out of the hospital, but also bring it back to the community and create this constant flow and network where we are engaging in primary, secondary, tertiary preventions to treat violence like the disease that it is. And just to end, does anybody know who this is a picture of?
Tupac.
Tupac Shakur. Yes, rapper Tupac Shakur. I'm dating myself here, but last month was the 25th anniversary of Tupac Shakur's murder, and he died at the age of 25. He was murdered. He was a victim of firearm-related homicide. He has since become an icon with paintings and music. But I think what is the true tragedy of Tupac Shakur's murder is obviously that he was murdered, but I think the true tragedy is that he essentially prophesied his own violent, traumatic death. If you ever listen to any of his lyrics and any of his music, he kind of really personifies the expected and accepted violent death that a lot of young Black and Hispanic men feel in these neighborhoods. There's a sense of inevitability that you will eventually be murdered. And if you listen to his lyrics, you hear that more and more and more. And I think he kind of resembles a lot of that mentality and of how individuals feel in the sense of hopelessness that perseveres, despite the fact that he passed away 25 years ago. His insight and his hopelessness persists in a lot of these neighborhoods. Through his lyrics, it persists. And the epidemic of violent trauma persists to this day. The COVID pandemic has worsened that. And he has a song where he writes, "Why am I fighting to live when they're just living to fight? Why am I trying to see when there ain't nothing in sight? Why am I trying to give when no one gives me a try? Why am I dying to live when they're just living to die?" And I think this really personifies this kind of mindset that people have in neighborhoods where they're living in such dire socioeconomic circumstances, such dire violent trauma, that it becomes inevitable, right? Over Memorial Day here at Jacoby at the end of summer, in the span of 72 hours, we had 16 gunshot wound victims that came to our hospital, 5 of whom died, and 2 of whom were brothers. So a mother lost 2 sons in one day from a single shooting incident. And it's not just the deaths that are devastating, right? It's the traumatic injury, right? We currently have a young man less than 18 years old who was hit with a stray bullet while he was playing basketball, who will now be paralyzed from the neck down. He will never be able to use his arms or his legs ever again, simply because he lived in a neighborhood where shootings happen. He was not involved in gangs, not involved in anything. He's an honor student who's going to college, just like all you all are. who will now be denied that right because somebody decided to shoot a gun. So it's devastating. The impact of these neighborhoods is devastating. And I think we need to really start treating violence like the disease that it is. It really is increasing as of late, and we need to really take it seriously and find innovative ways to treat it. With that in mind, I will leave you with this, and I'm open to any questions that you may have. This is a picture of the last peace walk that we had. We walked up White Plains Road from Pelham Parkway and White Plains Road all the way up to 225th Street and White Plains Road. And it was pouring for the first half. When we stopped on Gun Hill Road, it just stopped raining for some reason. And this rainbow just ensued right when we stopped there to get some water. And what was interesting about this picture was that it almost looks as if the rainbow is emanating from a sign for Past End Funeral Home, which is where a lot of our patients, unfortunately, go when they die to have their funerals. So to me, it was telling, but it was also kind of a sign of hope in that even amidst all of this violence, even amidst all of this loss, there is hopefully some hope that we can still mitigate some of these disputes to try to make a difference in both the neighborhoods and the patients that we see. So with that, I will end and ask for any questions.
Thank you, Dr. Romo. And you have a hard out at the top of the hour, is that right?
Yeah, sorry. Yeah, like at 5 o'clock, I have another meeting, so I apologize. So I'm giving you guys 10 minutes for a Q&A.
So let's take advantage. What do you guys want to know about any of this work?
I think the reason that there are gun violence is that there are loopholes behind around the New York City gun laws.
What do you mean by loopholes?
Like you said, they were imported illegally from other states that have looser gun laws.
Right. Yeah, and that's very difficult to control, right? The flow of illegal guns is difficult to control. Obviously, there needs to be better services in terms of identifying these guns, confiscating these guns, and preventing them from other states. But New York State cannot control what other states do. So that's why it becomes incredibly difficult if other states are not engaging in the same gun control laws. And until we have more of a productive national conversation regarding gun control, this problem is going to persist.
Dr. Romo, I just had a question. I mean, it's obvious that it's taken a long time to even get SUV up and running and a part of a New York City hospital system, right? How would you, and this is, I'm talking probably in the future of our public health careers, how would you encourage us to maybe think about creating similar programs at different hospitals or, you know, community clinics and things like that?
You know, so I think you have to start somewhere. When I first started this work 7 years ago, well, I guess it was as a fellow, even it was like almost 10 years ago, this was unheard of. Nobody was talking about this. Nobody was talking about violence as a disease as an issue. I was constantly told, you know, this is a criminal justice issue. It's a social work issue. It's not a medical issue. Why are you worried about this? Why are you trying to intervene in this? You should focus on something else, focus on diseases rather than violent trauma. And, you know, my answer was always simple. I said, look, I'm a pediatric hospitalist. I'm trying to take care of children when they're admitted to the hospital for injuries or for disease. And if children are getting shot and getting admitted to my service, that's my problem. And my job is not just to treat their illness or their injuries. My job is to also prevent them from getting re-injured or coming back with a disease. Otherwise, I'm not doing my job. And it takes some time to change the narrative. It takes time to change people's perception. And I think there has definitely been a swing in the direction of treating violence like a disease. I think there definitely is more attention. There's more national attention. I mentioned the involvement of Congresswoman Alexandria Ocasio-Cortez and Congressman Jamal Bowman. So it's more of a national narrative now because it's been so high. So I think this is a ripe time to get people's attention, the governor's attention, the mayor's attention, even the president's attention. You know, I think that it's important for us to really take a hard look at a lot of these socioeconomic factors at the base of that pyramid that I put up with the health impact pyramid and how we can make a difference. And I don't think none of you should count yourself short, and don't let anybody tell you that, you know, something is not a public health issue, something is not a medical issue. It's all about advocacy and also quoting the data. You know, I've also published on this work, which is critically important to get this work out there so it can be respected in the medical literature in terms of being published as a model that works.
Dr. Romo, you mentioned the Freedom Public Health Impact Model. which is
Yes.
the foundation for this course. Can you confirm that I did not prompt you to insert that into your presentation?
He did not prompt me, actually. No, I full disclosure, I have a master's in public health, a master's in epidemiology specifically. So no, me and Cap did not coordinate. We did not collude at all to make this impactful about his class. I was also, like I said, a master's student in public health when I did my fellowship in hospitalist medicine. So I'm well aware of it, and I always like to incorporate it into my talk to kind of really bring it into fruition in terms of how impactful it really is.
Right. So from that, we can sort of assume or predict, I guess it's a predictive model, that if we were talking to one patient at a time in one clinic visit at a time at the education level at the top of the triangle, how effective do you think that would be? Folks?
Not as effective as if you were working at the base of the triangle, right? So I think so.
Right.
Like if you look at our program, we've been trying to tackle every base of that program. I mean, we started at the top, and we kept going further down, further down, further down. We're trying to address the socioeconomic issues a little bit with what we're doing in terms of job training, education training, and trying to change the narrative in the community, trying to change community norms. But as you know, changing community norms, changing culture takes time. This work takes time. We've been doing this for 7 years. We've had some success, but nowhere near the success that we need to have. We are now starting to have the ear of national leaders, political leaders, people in Congress, people in the Senate. Chuck Schumer also came to meet with us. So, I think we're starting to change the national conversation, and we need to do that. People need to hear our numbers, need to hear our data, need to hear our stories, so that it becomes part of the national conversation, so that hopefully we can change the base of that pyramid. Hopefully we have a conversation around how things like issues around public education, issues around poverty, issues around social injustice affect people being victimized by violent trauma, and how addressing those underlying issues will ultimately help in the long run in limiting the degree of violent trauma that occurs.
Any last question that anyone wants to sneak in before we release Dr. Romo to his other obligations?
I just have a quick question about the social worker at the hospital. I'm doing the dual degree program in social work, so that's why I caught my ear. Does she do the counseling to prevent the retaliation that you mentioned? Is that her role?
So her major role is to help with any social work services, any linkage to therapeutic services, to community services. And as far as the mediation role, that's primarily done by our hospital outreach worker and our hospital responder, who is our credible messenger.
Cool.
Because that individual can better identify with the patients, he's the one that's primarily doing that. We also have another social worker who we just hired, who helps with the follow-up, and she helps in terms of the patient's need follow-up care. If they're in a cognitive behavior therapy, she's able to provide that therapy to them on an outpatient basis after they get discharged, if we identify something while they're admitted.
Cool. Awesome. Thank you.
No problem.
Well, thanks so much for your time, Dr. Romo. It was great seeing you again. It's sobering news. I love to hear the update every year, but it looks like we have more challenges in front of us.
Very much so. A lot of challenges ahead of us, but we're trying to continue full steam ahead. Thankfully, with increased national attention comes increased funding, so that's good. I don't particularly like the media. I don't like being part of the media, nor do I like engaging with politicians. Yeah. But it's unfortunately part of the deal when you do this work. And as long as you're doing it with the purpose of, increasing funding to get resources to the people that need it, and to improve an intervention to help save lives, then unfortunately we have to do that. And we're hoping we can continue to change the national narrative around this to continue to be an impact of change.
Thanks again, and hope to see you again next year, if not sooner.
Yeah, sounds good. You guys all take care.
Take care. Bye.
Thank you.
Thank you.
Thanks.
So folks, we have a little bit of time left. We'll try to end early, but I do have the opportunity to add in some extra commentary. So the prep question we had was a little bit convoluted on purpose. I just wanted to see if you guys could follow along with distinguishing the components of a multifaceted program such as Dr. Romo's. So I gave you the answer to part of it, up front, saying that when they encounter a victim in the hospital who has been assaulted, shot, stabbed, what have you, and they work with that patient and that patient's social network to prevent a retaliation, that is a long-lasting intervention, right? What characterizes it? Well, it's person by person, and there's a discrete course of treatment, right? It's not a clinical intervention, right? It's really easy to get confused with the word clinical. In the Freedom Triangle, clinical does not mean it happens in a hospital. What does clinical mean in the Freedom sense? Anyone?
Something that requires treatment.
And it's ongoing.
Ongoing. Repeated, no endpoint. So if you're talking about blood pressure medication, you take a pill every day, that's a clinical treatment. You're talking tooth decay, and you brush your teeth every day, you are the clinician doing the clinical treatment in that scenario. But if it's a discrete course of treatment, an endpoint in sight, it may take a few months, but if it's a discrete, predetermined course of treatment, that's long lasting. All right, but that's the part I gave you. So I went on to say, well, they do all these community-based events, right? Whether it's a political rally, right? A basketball tournament, a community event that's a celebration of some sort, or sometimes it's sort of marching down the street to bring awareness to each individual shooting that happens so that it does not go unnoticed. We call attention to these adverse events in the community where it happened. Where could those things fit on the triangle? Take a guess, it's okay.
I mean, it could be education and it could lead to like changing the context.
Right, so it's a bit of a trick question, but you answered it well because yes, it sounds like, wait, you're telling people stuff? Well, is that education? If it was one by one by one, I'm telling you, and then separately I tell you, and then separately I tell you, that's education. That's why it doesn't work. It's inefficient and ineffective. But how does it transform into changing context? What characteristic does it have to become not education, but actually changing context?
When it becomes a
Ubiquitous.
norm.
Say it again?
When it becomes a norm.
Yeah, well, when it becomes ubiquitous, it can become a social norm, right? When the message is ubiquitous, it can become a social norm, which does change the context. That's why we are wearing masks right now. Part of the reason. When you go out in public and wear a mask, it's often a social norm. When we are here in the building, sure, the social norm is there, but it's also a policy. Someone would come up to us and say, excuse me, could you put on your mask? All right, so that's one correct answer for the work that SUV does. It changes social norms. It tells you they're trying to spread the message, this violence is happening, it is wrong. We do not have to behave this way. We as a community can choose a different set of circumstances. There's another correct answer. What is that?
Long lasting.
Well, the long-lasting part we talked about, that's the hospital-based, set of services with a predetermined endpoint that happens person by person. But all of that stuff they do in the community, where else could that fall in the triangle, depending on how you define it?
Socioeconomic factor.
Say it again?
Socioeconomic factor.
Socioeconomic, exactly. Now, why might it fit right there? What characterizes things at the socioeconomic level?
Economics. So when he was talking about hiring people and providing jobs that people often can't get because have been formerly incarcerated.
Possibly, although that might be a person by person scenario, a little bit of a gray area. But what we're talking about in terms of the community-based interventions is that they're addressing the socio side of things, especially when it comes to relations with the police in the communities. So much of the violence is connected to the relationship between the people and the police. It's not always a positive relationship, as you know. It's just one manifestation of the larger issue around racism and class regarding poverty. So when they can get into the community and strengthen the social bonding of the community, reduce the racism, reduce the isolationism that comes with poverty, reduce the fear, all the barriers that prevent us from being positively interacting with each other. That's socio in the socioeconomic. That increases social capital, right? Remember, socioeconomic, to make it simple, just think about, am I increasing wealth, financial capital? Am I increasing social capital? So it does fit at the bottom of the triangle as long as you define your terms. Okay, any questions on that? I just want to make sure you guys feel really comfortable using the triangle. And then just to close out, in case anyone's confused about these terms, efficiency and effectiveness, I want to just clarify that a little bit. Okay, imagine a car. A car, picture that in your mind. You see a car in your head. Let's say it's a 2000 Honda Civic. Just a car. Fill it up with gas. Let's say you had enough money to fill up your tank with 1 gallon of gas. How many miles do you think you could go? Obviously, it's a rough estimate, but what do you think? What's a reasonable amount of miles you could go? Say it again? Maybe if it's a new car, perhaps. Let's say it's like a used car. Let's say you're doing a lot of city stop and go traffic. Let's say it's like 30 miles for that 1 gallon. So you put in 1 gallon, you drive continuously, and then you putter to a stop after 30 miles. So that car gets 30 miles to the gallon. So that's a measure of the efficiency, right? That's your fuel efficiency. Now let's say instead of a Honda Civic, you had a Prius. A Prius, which is a hybrid, right? It has a lot of batteries to recoup some of the energy that you otherwise waste during your braking process. So every time you step on the brake, some of that friction gets transmitted into energy in the batteries. So how many miles did you think you could go with a Prius when you fill it up with that same gallon of gas? What do you think? Just a guess. Do you go farther or not as far on the same gallon? You go farther.
You would go further.
Yeah, so let's say it's like 60 miles to the gallon because of that regenerative braking technology or whatever they call it. So if you have one car that gets 30 miles for 1 gallon, you have another car that gets 60 miles for the same gallon, which one is more efficient? The Prius. You're getting twice the fuel efficiency because you used a technological innovation. Now that's pretty cool. It's not the same thing as having an entirely electric car, but in terms of gas power technology, you've just doubled your fuel efficiency. That's pretty amazing. So that's efficiency. That kind of makes sense. How much bang do you get for your buck? So if those two cars are going along this way, and the Civic stops here, but the Prius keeps going all the way to here, that tells you in real terms how much better that Prius is in that sense. So that's efficiency. However, effectiveness Effectiveness lets you understand that regardless of which car you're using, it doesn't matter if your destination is over here. If you're going the wrong way, it doesn't matter how efficient you are. In fact, that could be worse if you're more efficient. You're more efficiently accomplishing the wrong goal. I know that sounds silly, but it comes up in real life situations. Meaning, for example, a lot of you might be familiar with QI projects, quality improvement projects. If you're in the clinic and they're trying to figure out, we need to speed things up here. We need to see, instead of 5 asthma patients per day, we need to see 10 asthma patients per day. So they're increasing which? Efficiency or effectiveness? Efficiency. But should the goal be to even have more asthma patients to see? Or should the goal be, let's have fewer asthma patients that exist because there's less asthma in the world? So I just want to make that clarification about efficiency, which optimizes the system you have, versus effectiveness, which is based on the values that you care about. So I don't care how efficient you are if it's the wrong value. It's going to come up. I know it sounds kind of like, why is he talking about this? It's going to come up. If it hasn't already in your professional careers, it's going to come up. Be wary of quality improvement initiatives, because what goal are they trying to accomplish? Is it making money, or is it actually helping the world? That's not always, they're not always in direct competition, right? We have to make money. But should we be making money by making sure people are sick, or making sure they're healthy? Anyway, we'll wrap it up there. It's 5:15 exactly. Thank you for your attention, and I'll send out some instructions about the quiz that'll be coming up. See you next time.
Thank you. Bye.
Thank you. Bye.
Thanks.
Thank you. Bye-bye.